All right, welcome everyone. Today we're going to take a really deep PhD-level dive into Chlamydia trachomatis. We'll be focusing specifically on its clinical side, things like urethritis, cervicitis, and of course, the really serious complication of pelvic inflammatory disease.
Okay, so here's our game plan. We'll start with the bug itself, move into how we find it and treat it, cover public health, then look at the long-term damage, and wrap up with some real-world case studies. Let's get into it.
First things first, let's get to know our adversary here. What is it about Chlamydia trachomatis that makes it so good at being a pathogen? What's its secret?
So here's the absolute core concept you have to grasp. This bacterium is an obligate intracellular pathogen. What that really means is it's a complete freeloader. It can't make its own energy, can't replicate on its own. It has to live inside one of our cells to survive. This makes it a metabolic parasite, and that's precisely why it's so hard to culture in a lab and so good at hiding from our immune system.
Now, this is where it gets really clever. The life cycle is basically a Trojan horse attack. You've got this tiny, tough form called the elementary body, or EB. Think of it as the infectious spore. It gets into one of our cells, but once it's safely inside, it transforms into the reticulate body, or RB. This is the replicative form. It completely takes over the host cell's machinery and just starts making copies of itself. Then, after about 48 to 72 hours, bam, the cell ruptures, releasing a whole new army of EBs to go infect more cells. It's an incredibly effective cycle.
And here's something that's absolutely critical from a clinical standpoint. Not all chlamydia is created equal. We have different strains called serovars, and they cause totally different diseases. The A, B, and C serovars, those cause trachoma, an eye infection. The ones we're mostly talking about today, D through K, cause the typical anogenital infections. But then you have the L serovars, L1, L2, and L3. These are a whole different ballgame. They're way more invasive and cause a much more severe disease called lymphogranuloma venereum, or LGV.
Okay, so we know it's a stealthy bug. How in the world do we actually find it? Well, it all comes down to hunting for its DNA.
This is a super practical point, but it's one of the most important for getting an accurate diagnosis. The sample matters a lot. For individuals with a penis, a first void urine sample works great. But for individuals with a vagina, a deep vaginal swab, which can be self-collected, is much, much better. It has far superior sensitivity compared to a urine sample, so you're much less likely to get a false negative.
You know, there's this great line from the literature about testing for oral chlamydia, and it kind of sums up the clinical thinking perfectly. If you're looking for trouble, you'll find it, but sometimes it's best not to go looking for what doesn't need fixing. And that's really the rationale here. Oral infections are often asymptomatic, they tend to clear up on their own, and so routine, widespread screening just isn't recommended.
All right, time for the counterattack. We found the bug. Now, how do we kill it? The whole goal here is to wipe it out completely, to stop it from spreading, and, just as importantly, to prevent all those nasty long-term complications.
So for your standard, uncomplicated urogenital infections, the go-to treatments are either a 7-day course of doxycycline or a one-time single dose of azithromycin. But, and this is a big but, the site of infection really matters. For rectal infections, the data is very clear. Doxycycline for 7 days is significantly more effective than that single dose of azithromycin. That's a key therapeutic distinction to remember.
And if you thought 7 days was a lot, check this out. 21 days. That's how long you need to treat LGV proctitis with doxycycline. Why so long? Well, remember those invasive L serotypes? Because they get so deep into the tissues, you need that prolonged 3-week course to be sure you've eradicated every last bit of the infection.
Now let's talk about newborns, because here the stakes are incredibly high. If a baby gets chlamydia during birth, you have to treat it, and you treat it systemically with oral antibiotics. If you don't, that infection can linger for years. And another huge point, you have to be absolutely sure it's not gonococcal conjunctivitis. If there's any suspicion of that, it's a true medical emergency, and that baby needs an immediate ophthalmology referral to prevent blindness. No delays.
Okay, let's zoom out a bit. We've talked about the patient, now let's talk about the population. How do we stop this thing on a larger scale? It's all about interrupting those chains of transmission.
And this is where we see a really interesting two-tiered approach in public health. A standard, uncomplicated case of chlamydia, not individually notifiable, though you would report an unusual cluster. But LGV? That's a different story. It is a notifiable disease. A single diagnosis of LGV triggers a mandatory public health response. Why? Because it's more severe and signals a different pattern of transmission that needs to be tracked very closely.
So the public health strategy really boils down to 3 core pillars. It's a simple but powerful playbook. 1, treat the patient and treat them fast. That's your #1 tool to stop transmission. 2, abstinence post-treatment. That's 7 days for a standard infection, but remember, a full 21 days for LGV. And 3, which is maybe the most crucial part, partner notification. You have to find and treat partners to break the cycle and stop the patient from just getting reinfected.
And now we get to the really sobering part of this story, the consequences. This is why we care so much about finding and treating chlamydia. Because if you don't, the damage it can cause is silent. It's severe and it can be permanent.
Just look at these numbers. They're staggering. We're talking about the risk of infertility in women after pelvic inflammatory disease, often caused by chlamydia. After just 1 episode of PID, there's already an 11% risk of infertility. But if that PID recurs, that risk doesn't just go up, it skyrockets to 40%. A 40% chance. That right there is the silent damage of this disease made horrifyingly visible.
And the risk to newborns is just as stark. Think about it. For a baby born to a mother with an active infection, there's up to a 50% chance of developing conjunctivitis. A 50-50 shot. And on top of that, a 22% chance of developing pneumonia. This is exactly why prenatal screening for chlamydia is so incredibly important. And believe it or not, the list of potential damage just keeps going. For women, you've got the risk of a life-threatening ectopic pregnancy or Fitzhugh-Curtis syndrome, which is an inflammation around the liver. For men, you can see painful epididymitis, scarring in the urethra, even a temporary drop in semen quality. And for anyone, the infection can kick off a systemic autoimmune problem called reactive arthritis, which can affect your joints, your eyes, your skin. It's a whole body problem.
Okay, that was a lot of information. Let's try to ground it now by applying what we've learned to a couple of quick clinical scenarios. Time to put that knowledge into practice.
All right, first question. Which specific serotypes of Chlamydia trachomatis are the ones that cause that really invasive disease LGV? Think back to those different personalities we talked about.
That's right, it's the L serotypes, L1, L2, and L3. And that distinction is everything. The D through K serovars stick to the surface, but these L serotypes are the ones that invade deep into the tissue and cause all that severe lymph node swelling you see with LGV. Getting that right is fundamental.
Okay, next question. This one is about treatment. For which specific site of infection is a 7-day course of doxycycline clearly the better choice over a single dose of azithromycin?
The answer is rectal infections. Exactly. And this isn't just a trivial point. This is a huge deal in clinical practice. The evidence shows doxy just works better there. So choosing it is a smart, evidence-based decision that leads to higher cure rates and less ongoing transmission. It's a perfect example of how knowing these details makes a real difference for patients. And that brings us to our final and maybe most important question. It's a provocative one to leave you with. We have this bug that's mostly silent, yet it can cause such devastating and permanent damage, especially to reproductive health. So, are we actually doing enough to fight it? Is our current approach really sufficient? That's the question that keeps clinicians and public health experts up at night. Something to think about. Thanks for joining me on this deep dive.